Kineret dosing. There seem to be doctors still stuck on the dosing issue with Kineret. I don't know if it's a money thing or if they believe they're taking a conservative approach because they think Kineret will cause too much immune suppression, but many CAPS patients are on more than 100 milligrams a day. I have an A439V mutation, which is described in some literature as FCAS and other literature as Muckle-Wells syndrome. I sit somewhere in the middle of those two on the CAPS spectrum, and right now my maintenance dose of Kineret is 200 milligrams daily with an option for a third extra needle if I'm experiencing breakthrough symptoms on any given day. Kineret was originally made for rheumatoid arthritis, which is a disease that gets called autoimmune and inflammatory. The truth is, nobody knows what causes rheumatoid arthritis, but the interleukin-1 receptor antagonist drug Kineret did not perform well for that disease, and many of the early side effects reported were reported for rheumatoid arthritis patients. CAPS is caused by mutations in NLRP3 that result in hyperactive formation of NLRP3 inflammasomes. That causes activation of interleukin-1 beta, interleukin-18 and Gaz-dermin D. Interleukin-1 beta in particular is a potent pro-inflammatory cytokine. When this was figured out, the interleukin-1 receptor antagonist drug Kineret was repurposed for use in CAPS patients by some very clever doctors. The best way a doctor can know if Kineret is working well is by asking the patient how they feel. Even if the labs look good, patients can get breakthrough symptoms. Breakthrough symptoms tell you that inflammation is still high and a Kineret dose increase should be considered. There is now literature to support this action for CAPS, and I have links to that literature in the description. No CAPS patient wants to inject Kineret more than they have to. It's not addictive and it hurts, but the reduction of pain and symptoms should always be the goal for patient and doctor. So my message to doctors is to please listen to your patients and don't let outdated knowledge or cost be the driver of these decisions that might be doing your CAPS patients more harm than good. CAPS is not rheumatoid arthritis.